Welcome, everyone. My name is Annette Johns, and I'm the Associate Director of Policy and Practice with the Newfoundland and Labrador College of Social Workers. I have the honor of being the moderator for today's education event, Recognizing and Treating Obsessive Compulsive Disorder. We have over 320 social workers from across the province registered for this event this morning. As we continue to celebrate Social Work Month and the theme, Social Work is Essential, we recognize the essential role of social workers in the delivery of high-quality services, including those done in collaboration with our professional colleagues, and promote social work practice through our continuing professional education webinars. Sessions that focus on a theory, therapeutic approach, or practice intervention always generates a great response. In previous CE evaluations, members suggested that working with clients with OCD will be a great CE topic for a webinar, and I'm so pleased that this is the focus for our webinar today. This webinar is a collaboration between the Canadian Association of Social Workers and the Newfoundland and Labrador College of Social Workers. The presentation will be approximately 75 minutes, and all the details you need, like how to access the slide deck, is available in the widget icons accessible across the bottom of the webinar platform. You can also resize and move around any of the elements you see on your screen to customize your viewing experience. We will have a designated question and answer period at the end and about midway through the presentation that I will moderate. So I encourage you to type in your questions using the question mark icon at any time, and I will begin asking them during the designated question and answer periods. Please note that only the presentation team can see these questions. So I now want to introduce our two speakers, Hazel Russell and Sandy Cook. Hazel is a registered social worker and works with Eastern Health's Child and Adolescent Mental Health and Addictions Program at Outpatient Psychiatry located in the Janeway Hospital. Her 25 years plus experience of practice includes community-based, hospital-based, and private practice in Labrador, Western, and Eastern Newfoundland, as well as clinical teaching at Mons School of Medicine and School of Social Work. She obtained her bachelor and her master of social work from Mons. Her clinical work has been with children, adolescents, parents, and families affected by a broad range of mental health concerns. Hazel supports a team approach in meeting the needs of young people and welcomes the opportunity to be involved in educational opportunities and community functions. Sandy is a registered psychologist with outpatient psychiatry at the Janeway Hospital. She attained her bachelor's degrees from Memorial University and her doctorate from Dalhousie University. She grew up in central Newfoundland and returned home to the Rock almost a decade ago after studying and working in a variety of settings in the US and Canada. Her clinical focus has always been with children, adolescents, parents, and families. Although she enjoys working with people with a broad range of mental health concerns, she is especially passionate about parenting-related topics and obsessive compulsive disorder. And she also appreciates opportunities to consult and collaborate with colleagues about virtually all topics related to mental health. So Hazel and Sandy, I'm really looking forward to your presentation this morning, and I'll now turn the virtual podium over to you.
So big thank you, Annette. So this is Hazel, and I'll be starting the presentation or the webinar. Big shout out to all my social work colleagues that are online. Thank you for joining us. And a huge thank you to Sandy from our buddies in the psychology field. It's wonderful to partner and offer this today. A huge big thank you to Annette for giving us the opportunity. We enjoy presenting and we enjoy this topic in particular. So we're hoping today to be able to share a little bit of information around what is often seen as a very complex and very debilitating disorder, OCD. We want to make sure that people are aware that we are certainly not the experts when it comes to diagnosis and treatment around OCD. What we can bring to you today is hopefully generate some discussion and bring some of our knowledge as it relates to diagnosis and treatment of OCD. So I will just kind of jump in and get us started, and Sandy will join into the presentation a few slides in. All right, so before we jump in and share some of our information and knowledge that we've gained through clinical experience, we are curious to know where your knowledge lies currently as it relates to OCD. So we're going to jump in and answer some of these questions. I see people are answering there. My slides are pulling up. So we got, how familiar are you with OCD? Okay, so not at all. You're wondering how you ended up here in the first place. So not at all familiar with it. Don't even know what OCD is, maybe. A tiny bit, so you got a little bit of knowledge there, but enough to pique your curiosity, and maybe that's why you're joining us today. Somewhat knowledgeable, which looks like we're having the majority of people so far that are responding, which is great. So having somewhat of a background gives us some idea that the basics may be there, and we'll focus a little less in that area. Very knowledgeable. So we have about 11% there right now, which is actually really good. Extremely knowledgeable. That 1%, that person can probably join us in doing our webinar. So, okay, so that gives us a good idea. So most people are kind of in the middle, which is exactly where we would want you to be right now, because hopefully you'll gain more knowledge from this webinar. So I'm going to skip ahead. Okay. Okay, have you encountered someone with OCD within your job as a social worker? So this is just a yes/no. And so we're looking at, of course, a broad range of social work field. And, whoa, okay, numbers are coming in fairly quickly, which is fantastic. Okay, so safe to say the majority of people would have encountered someone with OCD as you're working through your role as a social worker, whether that's out in the community, in the hospital, wherever that may be. And that could be somebody, that could be a coworker, that could be a client. So we're seeing high percentages there. Okay, yeah, fantastic. So 83% yes, 15% no. Our last one that we have is specific to the treatment of OCD. So we're looking at people's general knowledge base, and now we're looking at specific to treatment. So we're asking if you have actually been involved in the treatment aspect of OCD, which is the field that we would come from. I'll just give it a few seconds to generate those responses. So from a treatment perspective, it looks like we're having about close to 25%, about a quarter of people that have actually been involved in direct treatment of OCD. So hopefully that will generate some good discussions as we move through the webinar. And the people who have not had any experience in the treatment of OCD will also generate a different type of discussion, and that's exactly what we're hoping for. So that's 75% and about 25%. Close to it. All right, fantastic. Thank you all for answering those questions and for your input there. So we'll pull back to that. Again, it just helps us guide the depth of the information that we're going to present today. So we'll start with the very basic of what is OCD. So we know OCD, Obsessive Compulsive Disorder. What makes a cluster of symptoms be classified as OCD? So in order to consider that, we look back to the DSM. So for people who are not familiar, DSM is the Diagnostic and Statistical Manual of Mental Disorders. So of course, OCD is classified as a mental disorder. DSM is published and has been published since the early 50s by the American Psychiatric Association. And since its inception, it's been used to classify the mental disorders. The reason why we pull up DSM-4, TR, which just means DSM-4 text revisions that were made to DSM. The original DSM-4, 1994, the text revisions were made in the year 2000. So back then, OCD was classified and captured under the anxiety disorders. What has happened since that time, the latest edition of DSM is the DSM-5, which was published in 2013. So in 2013, OCD actually shifted from the anxiety disorder classification into a classification of its own, along with a couple of the other disorders. And that classification is known as the Obsessive Compulsive and Related Disorders, OCRD. The other related disorders, for people who are interested, they include hoarding disorder, trichotillomania, which is hair pulling or hair plucking, excoriation disorder, which is skin picking, and another fascinating disorder, they're all fascinating, but body dysmorphic disorder is also classified there. So they've developed this classification of its own, and underneath that, the criteria that we have there, A, B, C, D, we'll just kind of briefly go over those. So in order for a diagnosis, so the DSM gives us the classifications, and under the classifications gives us criteria for diagnosis. So the diagnosis around OCD, A, is the presence of obsessions, compulsions, or both. You'll see there's a star there because that will come up in a later slide that we'll discuss that a little bit more. Even though we say obsessions or compulsions, we actually see the combination of both more frequently than we would see them separate. The obsessions and compulsions for Section B have to be time-consuming, which the qualifier there is greater than 1 hour a day. So time-consuming, or there, I can tell you just from a clinical perspective, there's less of a focus on the amount of time that somebody is spending. That's kind of less of a focus than on the secondary ones, which is that it actually causes significant clinical impairment or significant clinical distress. So those are huge qualifiers. So the person's symptoms are interfering with their daily functioning. It's taking up a lot of time. It could mean you're spending 2 hours in the nighttime doing checking rituals. That's delaying your sleep. It could mean you're showering for 3 hours in the morning before school, which makes you late for school. So we're looking at significant impairment, functional impairment, which is what we look at when we consider something as a disorder versus symptoms. C says it's not attributable to a substance or a medication, and this is kind of outside of our scope of practice, but just for people who are curious, a medication that might minimally be associated sometimes with mimicking OCD symptoms would be a stimulant that contains an amphetamine, which would be something like Adderall. When it comes to substances, some of the stimulants, such as cocaine, might mimic some symptoms. Something that might be attributable OCD symptom-like, but would be attributable to another medical condition. You may be looking at things like dementia, delirium, another a psychotic disorder, something. So it's ruling all of those things out, or ruling them in, either or. So that's C. And D is that the symptoms are not better explained by another medical disorder. And for anyone who there are some of the things that he talked about. So eating disorders can look a lot like OCD. because there's preoccupation, and the preoccupation is with food oftentimes, and then there's very ritualistic activities that might look like compulsions as it relates to preparation of food or eating. But those symptoms are specific to the eating disorder, so that would be explained by an eating disorder as opposed to OCD. Okay, so now we are, so my slides are hopefully, okay. So we're moving on to the demographics around OCD. So how prevalent is this condition? We're saying it can be quite debilitating. When we look at the numbers, the latest statistics, so these are Canadian statistics, we're looking at its effects approximately 1 to 2% of the population. The onset usually begins in adolescence or young adulthood, although we do see children with OCD symptoms. But typically, as with most of the mental disorders, you do see an onset in adolescent years. And of course, we work in an adolescent clinic, so that's why we would see it a little more prevalent. At least 1/3 of those who experience OCD as an adult have had it since childhood. It's also known to be more common in childhood, known to be more common in boys than in girls, but more common in adulthood in women than in men. So Sandy and I had several discussions about what might account for some of this, and I don't think the research is even clear on what accounts for it, but we know that, that's what the stats are showing. Okay, so take the pressure off me a little bit and put it back on you guys to ask you to answer this question. So what is an obsession? Is an obsession a thought? Is it an urge to do something? Is it a mental image? Or is it either of the above? Well, look at that. People are answering very quickly. Okay. So we're not having people buy in much to a mental image at this point. This technology is wonderful in being able to see the results as they're coming in. Okay. So we still have a little bit, but it looks for the most part. Okay, for the most part, we're having people side with D, which is that it can be either of the above. So it can be a thought, an urge, or a mental image. So if that is, okay, so about 80%. So let's try another one and get you guys thinking about what is a compulsion. Is a compulsion a physical act? A mental act? Is it rumination? So rumination is just a focus on the thinking and overthinking. Is it rumination or is it either of the above? Okay. And of course, we're asking these questions knowing that we haven't given you a whole lot in relation to or even given you any qualifiers with respect to what these terms even mean, which we will get into. Okay, so we're seeing the numbers climb, kind of a similar presentation to the answer around what is obsessions. Alrighty, so okay, so our final total about 80%, which is similar to the other one. So we're having about 80% of people that would put obsessions and compulsions as either of the above. That is certainly a reflection, I think, of the knowledge level, which would have been at the beginning questions that we asked. So the people who didn't think they were very familiar with OCD might realize that they actually are more knowledgeable than they realized. So high percentages that actually reflect accurately what obsessions and compulsions are. So we're going to look a little bit closer at obsessions. And so we will start with an obsession can absolutely be either a thought, an urge, or a mental image. So a thought that it would be considered and classified as an obsessive thought is oftentimes very bizarre. It is always recurring. It's always persistent. It can be very intrusive, and I think when I hear young people talk about it, the intrusive part is probably the best descriptor. So it's unwelcome. It's something that just kind of, this thought just pops into your head, and it can be very, very distressing. An example of some of the bizarre thoughts, so just from, I guess, my clinical experience, an example would be a young person who I saw at the age of 16, but since the age of 10 years old, so pre-puberty, the young person, a female, was having this really intrusive thought that she was pregnant, and had consistently had this recurring thought since the age of 10 that this pregnancy thing is a real thing. The thought is there. She fused with the thought to believe the thought that she could be pregnant. This went on for a number of years, and of course you would see once puberty struck, we had an increase in those thoughts. Even at the time when I saw her, at 16, the intrusive thought of being pregnant was very prominent, and she is a virgin. And so I'll talk about some of the approaches, some of the things that she did to kind of manage this ongoing thought that she had. Had another young person who had a really bizarre thought that she might wet her pants in public, and was so consumed with that idea that she would wear a Tens, and then she eventually stopped going out in public altogether. So some of these thoughts are very, very bizarre. We often, we'll also see just thoughts that are they're so not in line with what the person believes themselves to be. And so they create a huge degree of distress. So an obsession can also be the secondary one. We're going to give lots of other examples. It's just kind of something for people to think about. The urge one is, it's not an actual thought that people can identify. They just feel like they have to do something. So that urge is the obsession. So it might be the urge to tap. It might be the urge to, I'm going to touch on one thing with my right hand. I need to touch it with my left hand. They can't describe why they need to do that, or even what would happen if they didn't, but they feel this enormous urge to do that, to follow through, because it doesn't feel right if they don't. The mental image are oftentimes, young people would describe it as like a movie that plays out in their head, and it's very short. It might be like 1-2 seconds sometimes, but it's quite vivid and it's quite intrusive. So a mental image is very, very disturbing. I had a young person who would have a mental image during class of her sister hanging from rafters in front of her. We have them with, I had another young girl who every time she was in a car, in the backseat of the car, her image, constant mental image of her mother dying in a car accident. So they can be quite debilitating. What happens is once an obsessive An obsession is automatic and outside of our control. It creates, in the arrows there, if we wanted to, we could actually highlight the distress that the person feels as a result of the obsession. So that's where the anxiety piece comes into play. So what happens once the obsession is there and there's high degrees of distress and anxiety associated with it, these compulsions are in response to the anxiety, the distress, and in response to the original thought or urge or mental image. So the compulsions can absolutely be either of these. So you can have a physical act, which is something that you would see. So that might be some of the routines or rituals. That might be like somebody, who's cleaning their hands to the point that their hands are raw. So it can be a physical act. It can be a mental act. Some of the mental compulsions that you might see would be things like counting or prayers. Or it can be, we have it here as nothing, but we have it as rumination. So the compulsion might not be something that you can see, or something that the person is actively kind of doing on a regular basis in their head. But the rumination part is high degrees of overthinking. And they're overthinking, scrutinizing maybe a situation that just happened where, say, if it's about germs, they might think that they've exposed themselves to germs. And so they will scrutinize their day and go back over their day and question, and they might even question where this thought came from, and they'll question everything that they did, and they'll get caught up in the circular thinking and the rumination, and they get debilitated by the rumination. I have a young girl right now who's so confused and stuck on her thoughts, she can't make it through a shower because her thoughts are just so consuming. So it can be quite debilitating. And so when we look at, how does anxiety how does anxiety fit into this? Whoops. Sorry, I moved ahead too quick. Okay, so this is just a little visual of what I just described. So you'll see this referred to as the Ocd cycle. So if we start with that obsession, again, that obsession is the piece that the person doesn't have any control over. It's automatic, it's intrusive, it's something that's happening to them. The response to the obsession is where the anxiety piece comes in. So it's creating high degrees of, so some people will refer to it as anxiety, but other people might refer to it as distress or disgust. But there's an emotional reaction that's connected to, in response to these obsessions. The compulsions come into play to try and reduce the anxiety, and in some ways try and either suppress the obsessions or make it less likely that the obsessions will actually become truth. So if I have an obsessive thought of hurting somebody, then the high distress that creates for me, and then my compulsion might be, to do something that's going to make it less likely that that thought I have will actually come true. So the obsessions create that emotional reaction, and the compulsions are what we do to try and manage and contain that. But the compulsions people get caught up in because they only provide that very immediate temporary relief, but they're not enjoyable activities. This is not, somebody cleaning for the sake of having pleasure. This is somebody cleaning because the obsessive thought is about germs. So they get that immediate little sense of relief, and then the obsession we actually feed into a feedback loop, which creates an increase in symptoms. Okay, so I am now going to pass it over. So
All right.
I'm now going to pass it over to Sandy, so you can pick up there.
All right. Hi, folks. Thank you so much for signing on. We hope to provide some information to you that might be new in your to bring to your jobs. Okay. So Hazel's actually done a fantastic job to the point that I actually don't need to say a lot about these slides. I'm just going to go through and to indicate a couple of things. So we're going to give you some examples of symptoms. So let's look first. Wait now. Okay. Trying to, okay, sorry. Okay, figured it out. Okay, so let's look first at that obsession. When there is a particular thought, let me first tell you, remember that star we showed you back in the DSM criteria? Because the DSM said there's an obsession, you can see either obsession, compulsion, or both. I can tell you from a treatment perspective, you actually need to see it as exactly as we have it outlined here, that there is an obsession. It's just that the obsession can take either of these three forms. And so once you recognize that, now you can figure out like, oh, okay, I see the obsession. I'll use that language regardless. Even if I'm dealing with someone who's simply just having those urges or they're having images, I'll still call it obsession because just to keep it simple or straightforward, okay? So first we have that obsession and then the compulsion follows. But remember how Hazel explained how sometimes it appears to be nothing. And so, and I've sat in my office and talked to people like, what do you do? What do you do? And they're like, I don't do anything. I just think through my head, like, you know, like Hazel said, like where might I have come across those germs? Or, and we'll give you some more examples of how people get into the rumination, especially with images. And so it's easy for some people to think, oh, okay, then there is no compulsion. We certainly don't physically see someone doing something. But again, if your goal here is treatment, you really need to kind of dig sometimes to really see what is the compulsion and recognizing that indeed it can simply be that rumination. Okay, so sorry guys, I'm automatically going to press forward on my arrow key and it's not working. All right, so let's look exactly at the examples of thoughts. And right away, if you look now on what I pulled up, see 4 things there on the left. Those are themes that can happen with obsessions. And I'm a very detail-oriented person, which is probably why I love working with OCD, because sometimes you have to get really, really detailed about exactly what someone's thought process is and exactly like what behavior they might be engaging in. You will see it, so it helps for me to organize my thoughts when I'm working with someone according to the themes of their obsessions. So I'll give you some examples here. So let's take contamination. That's the one that usually people come in and are familiar, like usually you're familiar with, like, oh, you know, OCD is like when you wash your hands all the time. It's far more than that, but certainly it can be. The thought might be, and if you see me looking down, it's because I'm looking at my notes to make sure that I give some examples, all right? And I apologize that I have COVID hair. Hopefully that can get edited out from the video. Okay, COVID hair, meaning I haven't been able to get my roots done. All right, so contamination. The thought might be, oh, if I touch that, I'm going to end up getting warts. The examples that I give, by the way, are all going to be examples of people that I have indeed worked with. Okay, so I had someone once who avoided, his brother had warts. He had warts as a young child, and he became quite preoccupied with this idea that he might get warts, and this was just simply not acceptable to him. So the thought was, if I touch this, I'll end up with warts. So he would go around like wearing Band-Aids on his feet and socks and wouldn't sit in any furniture where his brother sat and so forth. I had another person whose thought was, you know, they'd use the toilet. They do a poop and then they wipe themselves with the toilet paper, but the thought would be, I'm not clean, I'm not clean, I'm not clean. I had a young person, the example I'm going to give later when I show a ladder. This is a cue. This is the kid I'll be talking about. This kid, his thing was, there'll be microbes. That was his exact words, that there'll be microbes and things that he might touch. Okay. So again, we see specific thoughts there related to contamination. And then the compulsion is that I'm going to wash. I'll wash my hands. I'll get in the shower for, you know, hours or whatever. Or I'll wipe myself. That's after using the toilet. People absolutely will wipe themselves to the point that they actually, the skin will get sore. We'll also see cleaning. That's when, you know, people are like cleaning obsessively any surfaces that they might feel might be contaminated with any of these germs, or they'll avoid. And let's be honest that the reality is that's exactly where a lot of people will end up early, if not at some point, is like it becomes too complicated, so they simply avoid. Like that fellow with the warts, he probably still does a very isolated life, but he wouldn't leave his bedroom because when the brother came home from university, because the brother would be contaminating anything and everything that he might touch. Okay. I have a star there because the star is just a cue me to say that sometimes you will work with people with contamination compulsions. You see the washing, the wiping, or what have you, and they actually aren't able to tell you, surprisingly, they aren't able to tell you what their actual obsession is. It's just simply like, they might say, oh, I just need to clean. I'm not clean. But it doesn't get into anything specific like warts or microbes or what have you, okay? The next example is somatic. Somatic is simply a fancy way of saying body. So it's a body-related obsession. So for example, it might be like, I'm going to have a heart attack. Like I have a kid on my caseload now, 18 years old, perfectly healthy young fellow, but convinced he's going to have a heart attack. That was last summer, and now it's shifted to now he has an obsession that he might lose his memory. That was 2 weeks ago, and now it's shifted to I might get schizophrenia. Okay, I've also had people say, "Oh, I think I have ringworm or a brain tumor," and so the compulsion then is they'll seek reassurance. Okay, so they will go to a doctor, and the doctor, like the heart attack fellow, has had an MRI and an ultrasound and blood work, et cetera, et cetera. That's reassurance seeking going to the doctor. The results always come back normal, for these folks. Or they'll actually go to a parent, like, Mom, look at my leg. Like, look, I think I have ringworm. And they go to the family doctor. Or they'll get on the internet. That's another big one, is they get on the internet and they start searching up all their symptoms. And I can assure you that Dr. Google will diagnose you with anything if you keep looking, right? So that can get quite dangerous in terms of what impact that can have on people with OCD. They often don't get the reassurance that they're seeking. They just get more and more obsessions. Let's shift down to superstition. This one's fascinating because we all have superstitions, like 13 is an unlucky number, or don't step on the cracks on the sidewalk, and so forth. And you can absolutely see some people with OCD that's exactly the superstitions they might have. They've just, like, the superstitions are kind of like exploded and they've taken it to a whole new level. Or you can have and typically you'll have superstitions that are like, my gosh, that's bizarre, quite bizarre. You'll see at some point, we'll hopefully make this point, so I'll make it briefly now, that it's absolutely feasible, and you cross your fingers and hope that people recognize that they're thinking that these obsessions are bizarre, okay? Is it possible for someone to truly believe it, like cross their heart, this is the gospel truth, that if they step on the crack, their mother will die, so they won't step on any cracks in the sidewalk? Yes, you will see that, okay? And we will talk about that when it comes to treatment, okay? So let's give some examples of superstition. I worked with a fellow years ago, and this fellow in particular really makes me sad because he had spent years with these obsessions and had no idea that there was something that could explain this. His worry was he would get sick, he would vomit, and he wouldn't get in the car to go anywhere because that might make him motion sick and he would vomit. He'd never. I think that was one time he had vomited in public. But he would have in his mind certain lucky clothes. And it's not something I particularly pay attention to, but after months of working with this fellow, and he lived outside of town an hour and a half, so it was a big deal to come in the car. And I would notice he was wearing the same clothes over and over and over. So finally, I actually brought it up, and sure enough, these are his lucky clothes. In his mind, these were safe clothes for traveling on the road, okay? And that meant he wouldn't get sick. Some other superstitions. This one's really fascinating. I once had a kid that her thought was, if I pour milk like my mother or father or whoever, I don't remember who, or if I sit in a chair like whoever, I could become that person. So superstitious belief is like, okay, I can't pour milk that way, or I can't sit in the chair that way, because that's what we call a morphing obsession. So notice how the compulsion then is, I need to do a particular behavior, like wear the clothes this way, or put this one on the right leg and then that one on the left, or whatever. Or it might be, I don't do X. I can't pour the milk that way because then I'll turn into my mom or whatever. Okay, so those are some examples of superstitions. And then there's self-doubt. There's an element of doubt in all OCD that like, I can't take the chance, that uncertainty. And so that's why you get engaged in the compulsions, because I'm not going to take the chance to play this out and see any of this come to fruition. So self-doubt is there for all of them, but in particular, when we think about this theme, these are the checkers. These are the people that are going to take the stove is off, or the straightening iron is turned off, or the windows are shut because, you know, someone could come in at nighttime, or the door's locked, or they're checking their closets because they have this sense, oh, someone is watching them, or they're checking the heaters because, you know, the curtain could be on the heater and they could start a fire. Shoot, I just had a thought and it's gone now. It'll come back to me. Okay. Oh, you also will see with the people that have those doubting obsessions, they might also seek reassurance. Okay, so you'll see a lot of reassurance seeking in OCD. And so that's when they're going, did I turn the stove off? Did I turn the stove off? I have one girl, she's quite debilitated by OCD, and she regularly goes to her mom. So I know how her OCD is doing based on the number of questions she asks. She'll say, will I be okay with my thoughts? Will I be okay with my thoughts? So it's seeking reassurance. Okay, now let's go to compulsive urge. That's that feeling, like Hazel said. It's almost like when you have to cough or sneeze, and y'all know, like, no, I just need to cough and then I'll feel better. It's not exactly, but the gist is the same. It's that feeling, like a bad gut feeling. I'm not able to relax until I do this compulsion, and there's nothing more straightforward than that. Sometimes, if you really push, for some people, they might be able to say something bad is going to happen if I don't do this tapping or whatever it is. And sometimes it's particular. It's very specific. If I don't tap in this particular way, my girlfriend will die. I have someone with that particular theme, that obsession. But oftentimes it really is just, for this in particular with the urging, you really truly just get that, I just have that sensation of a bad gut. And the compulsion then is to create symmetry, like I'll call it paired actions. And I don't know, I'm not able to shift myself. I'm not visually, spatially strong enough to be able to figure out how to move my body so you see this. But I'll tell you, I call it paired actions. That's my own language. But it might be like someone touches something with their right hand, and then they need to touch it with their left to kind of neutralize or undo it in their mind. And so things need to be even, or lining up books a particular way, or counting is also another one that, like, I think Hazel referenced that as a mental compulsion, like counting steps or so forth, or brushing their hair to a certain number of strokes. So it's an idea that, you know, I need order in my life. Okay, repeating is, again, it's just the urge. I can't explain to you why I need to do it, but it might be something like, I have one kid that would say something and then he'd repeat himself like under his breath. And he wouldn't necessarily even realize he was doing it. Not in an echolalia autism kind of way, but just randomly every now and then there might be repetitions of something he said. You will also see, this one people will often see is they write something, they'll do homework or try to do schoolwork, and then they go back and erase and redo and redo and redo. Sometimes there's the very clear obsession of, like, it's not perfect. They need it to be perfect, but sometimes that thought is not even there. Or it could be something they've done, like they go up the stairs, but it didn't feel right. It didn't go up the stairs the right way, so they go back and they go up the stairs again. Oh no, still doesn't feel right, and they'll do that again. So getting through a day, as you can imagine, can be very tough. Going through a doorway is another one. The rituals, this one's interesting because this is the one that pulls other people in. Oftentimes, no, not always, but oftentimes, people can have rituals, for example, with hand washing. I mean, I worked with the girl with the poop germs. Everything was about poop germs. Her ritual was fascinating for hand washing. I mean, she would wash parts of her hand I would never have paid attention to with myself. But it would be like step number 1 would be 3 pumps of soap, and then it would be turn on the water a certain way, and then it would be, you know, the right hand from pinky to thumb, and then the nail beds, et cetera, and then the wrists, and there was counting. Complicated ritual. Or you can pull someone in, like a ritual at bedtime is, I love you. Now the parent needs to say, good night, I love you. And then I love you too, or I love you more than the moon, or you know, who knows what. And the parent has to respond a particular way. And the parents will often do it because it's truly the only way that you can kind of move on. The child can relax enough to go to sleep. Let's move on. This one is fascinating. Again, we referenced the mental images, and some of you might not have been aware that indeed there can be mental images. And this is what's fascinating is, you see there in red, it says taboo topics. All right. So if someone comes to me and I find out that they're experiencing these mental images, they may be triggered by something they've actually seen. They see cars in front of them while driving on the road, and all of a sudden they have images or little mental movies of car crashes. Yeah, okay, that's triggered. Or it could be random, like Hazel described, the kids in the classroom, and all of a sudden they see a hanging body in front of them. But typically, if someone's experiencing images, it's always to do with the taboo topics. And these are these three right now I'm going to pull up. One is violent. So there's violence, there's blood and guts and gore. And truly nothing is kind of off limits in terms of what you can see there. Or there's a sexual theme to it. And so that might be images, and it sounds horrendous, and you can only imagine how horrendous it is. It might be images of being raped, and raped by a family member for that matter. Or it might be images that they see breasts everywhere. Or, I had one girl who would have images of porn playing out in her mind. Not what you want. This is not enjoyable. And nothing about OCD is enjoyable. That's part of the definition, that it doesn't fit with who you are. The scrupulosity is just a big, long, fancy word to say that it has to do with your morals, who you are as a person. And so the images you don't often see to do with morality. An example might be someone who sees they see sixes in their mind, and 666 makes them think of the devil. Okay, and then they think like the devil is going to take their spirit or something. But again, mental images typically are violent and sexual in nature. And then the compulsion will be to ruminate. So, for example, you have an image or a mental movie in your mind of, taking a machete and just driving it into the head of your father, and you're literally just walking down the hall in your house. And then the ruminate is, oh my gosh, I'm clearly a psychopath. Or you have a thought come in your mind of, oh my gosh, like you see a child, and the idea of having sex with a child occurs. Oh, I'm a pedophile. And so now there's meaning attached to these obsessions. And then the rumination is, oh my gosh, am I a pedophile? And then they actually might go seek reassurance to see if indeed they are a pedophile. Or you can have people who, might identify straight or homosexual, but the obsession is that they're opposite. So they might identify as straight, and the obsession is, no, I must be homosexual. I must be homosexual. So then they go out and seek, and actually rate how attractive, or they'll go intentionally look at people of the same sex and think, okay, am I attracted to them? I'm look for the evidence to see if indeed they are homosexual. Notice there, so again, you get these patterns of ruminating and seeking reassurance. Notice that under the scrupulosity, this one's fascinating. Again, morality, this is often guilt. There's a tremendous feeling of guilt that they might have said or done something that suggests that they aren't, quote unquote, good people, honest, law-abiding citizens. So something like, and these taboo topics, although, if you're going to see images in OCD, it's going to have one of these themes, but you can absolutely also have a very clear obsession or thought that has these themes. Like, for example, someone who has this thought of, oh my gosh, I just did something bad. Did I hurt your feelings? Did I hurt your feelings? Are you okay? Or I have one girl on my caseload who, would have, this idea that she might have posted on social media that she said something inappropriate. And so then there's checking, or there's apologizing, like, oh, I'm sorry. Did I offend you? I'm sorry. Or confessions like, Mom, I just told my brother to stop doing that. I'm sorry. Or I just called my brother a brat, and there's guilt. So they need to confess and tell someone. Or you pray. The fellow who wore certain clothes, he also, because you'll often see that people will have more than one theme. In fact, 2/3 of children have more than one theme to their obsessions. The kid who would wear certain clothes, remember, he'd come in over the highway and he had to wear certain clothes so he wouldn't get sick. He also had prayers, and it would be particular prayers. And so so you want to be careful. This is not like, oh, well, I just pray whatever's on my mind that day. This is a very scripted prayer, like, please God, don't make me sick. Please God, don't make me sick. Okay. Have we lost Hazel?
Hey, yeah. Sorry, my screen actually disappeared that time, so sorry about that. Okay, this is just a quick reminder. It sounds like we have a lot of knowledge already online specific to OCD, but I'm sure even more so in relation to anxiety disorders. So the fact that we have a roller coaster up there wouldn't come as any surprise to people when we talk about symptoms and symptomatology. So when it comes to obsessions and compulsions, no different than any of the other anxiety-based disorders where you will see that waxing and waning over time. So you might see an escalation in the presentation, and then you might see a leveling off, and then you see another escalation, and people get those little breathers in between. You might also see, and Sandy referenced this earlier, that switching up over time around the themes. So oftentimes you will see more than one theme, but within a theme you might see different presentations and how those things play out. But you will see those symptoms that kind of do that escalation and then leveling off for a period of time. What we can say, I guess, clinically, what we often see is that escalation, as it is with anxiety, oftentimes triggered from stress responses. So a young person that I actually just spoke to yesterday who had this very detailed nighttime ritual for the past year, 2 weeks ago, 3 weeks ago, corresponding to level 5 for COVID restrictions, there was a huge escalation in symptoms. So sometimes you will see that. Sometimes it might be something obvious, sometimes not as obvious. But the fact that the symptoms are waxing and waning over time is actually what we expect with OCD, no different than what we would expect with any of the other anxiety-based disorders. Okay. Okay, so I'm just gonna talk briefly about this obsessive compulsive personality disorder, OCPD, because oftentimes when people see obsessive compulsive personality disorder behaviors, it's classified in the OCD category, and it's two very different presentations, although you might see some similarities there. So we thought it would be important to kind of distinguish it. And we hear this a lot of times from young people. So if they're very particular, we'll say, about orderliness, which is what OCPD is driven by, that need to have things a certain order, the need for things to be in control. Somebody with OCPD, which is personality disorder, they strive on routines. They have to have things not just a certain way, but their way. So these people very much like to be in control of their environments and their lives, and how they kind of play that out is actually quite pleasurable for them. So the reason why we have the picture of a person who's cleaning excessively there with a smile on their face would be the cue that this is not a person with OCD, because that attention to detail for cleanliness when it's a compulsion is not an enjoyable activity. So it's contrary to what it is that's fitting for them and their values. So somebody with OCPD, this fits for them. This makes sense for them. They don't see anything wrong with this. So if you have somebody, for example, the picture we gave that we have there in the office, if you are working with somebody who's OCPD, they're actually, they do fantastic work. So OCPD is also driven by perfectionism. So the quality of the work that they provide is oftentimes, like it may even exceed the expectations, but they hold other people to the same standards that they hold themselves. So they're very intolerant of other people if they don't meet those standards. So what you'll find if you're working with somebody, for example, with this personality disorder, they're great if you let them take the lead on things, and they're in control and they will produce good work. But if you want to have input and your input is not the same as or in line with their expectations, then you're going to see conflict there. So OCPD is driven by, they're so focused on how right things need to be by their own standards and how they see the world, that it's often at the expense of flexibility, which interferes then with interpersonal relationships. So you're seeing that, but the activities or behaviors that they engage in themselves, though, the reason why we have the stress kind of X'd out there, it's not stressful for them. Like, it's not stressful, it's actually enjoyable activities for them to partake in, because it fits with their own values and how they see the world. Versus, again, somebody with OCD, you're not going to see that somebody with OCD would have to be doing a list because it's compulsion. Somebody with OCPD is doing a list because it's enjoyable for them to be doing that. So we just thought we'd kind of throw that in there just so people would be aware of that. And Sandy, I think the next is yours.
Yeah. Okay, so just one last thought on that. And by the way, this is our last slide before our midway point. So we're actually doing pretty good, even though we're almost oh, wait, no, we're actually not doing that well for time. Sorry, folks. This is our last slide before we're going to check and see if there's a couple of questions, and we'll go to the treatment thing. The treatment part of our presentation. One last comment about the roller coaster is that if you look at, like, so am I on a roller coaster for life? Not necessarily at all. So early treatment is obviously the better the outcome long term. But if untreated, 1/3 to 1/2 of children will still naturally remit. Their OCD will remit by adulthood. Okay, even without treatment. Okay, pandas, I'm just going to bring this up briefly because it's fascinating. It's been around since it was first put in the literature in 1998. It's the idea that for sometimes in children, age 3 to puberty, you can get, is not formally diagnosed or recognized by the DSM-5, but what happens is there's a sudden onset of OCD, often occurs with tics, but it's associated with the streptococcus bacteria. So you'll sometimes see like strep throat. It might not be strep throat. The strep bacteria could be somewhere else in the body. But all of a sudden, the person presents with OCD, literally within hours or days of that infection. What's happening is the parts of the brain that are known to be associated with OCD are kind of being attacked by the antibodies produced to fight against the strep bacteria. So it's an autoimmune condition. Those antibodies actually attack the basal ganglia, part of the brain, and all of a sudden you end up with OCD. And you'll hear parents talk about it. I've seen a handful of cases over the years. You'll hear parents talk about how, this is not their child, and they can literally date it back to a very specific time. Okay, so I'll give you some other symptoms that you will see if indeed PANDAS happens. And this is a whole topic in and of itself, a fascinating one. But if anyone has any particular questions, probably best that you ask a specific question rather than you just kind of go generally about PANDAS and so forth. And sometimes people have questions about how do you even begin to treat it and so forth. Generally, the treatments are exactly the same. You'll look at medication and therapy. Other things you'll see, I said that, you'll often see it occur with tics. Those are like motor or verbal things that people, like quick little things like a throat grunt, or, squinting of the eyes and so forth. You'll often see symptoms like ADHD symptoms. Sometimes you'll see separation anxiety, like the child became hugely clingy and all of a sudden just wouldn't leave the parent. You'll see huge mood changes like rages. And like this is not the typical child. You might see someone having trouble sleeping, or all of a sudden they're wetting the bed when they've been trained for years, or it might be wetting themselves during the daytime. You might see a regression in handwriting skills, or you'll see joint pain, or this is someone who all of a sudden just stops eating, and it could be for any number of reasons. All of a sudden they think their food is poisoned, or they think they're going to choke, or they're caught up with their body image and in an obsessive way. Okay, so that's fascinating. It's very important to be aware of because you want to get in there with early treatment, especially if the strep bacteria is still active and you give the antibiotics, you can see the decrease in symptoms. These people in particular, you'll see a huge waxing and waning according to often how physically well the child is. And it doesn't necessarily last, for life. It often, might dissipate after, they're recovered from the strep, or it can continue on. Okay. Any questions thus far? And if not, that's okay. We'll roll right into the treatment.
We do have 2 questions there right now, so maybe we can look at those, and then we can move back into the presentation. The first question is in terms of, I guess, related to COVID. Have patients living with OCD been more debilitating in their daily lives since the pandemic, and have resources been more difficult with some closures?
Oh, closures of businesses or something?
Yes.
Okay, so I don't know if I caught the last part to that question, but I'll tell you first what this COVID thing. So yeah, it's fascinating, and there's 2 things to think about when it comes to COVID. Number one, my first gut reaction when COVID hit a year ago was, oh my gosh, what about the people on my caseload with contamination obsessions? And all of a sudden they're convinced, anything they touch, they're going to end up with COVID. Or, the somatic obsessions, they're convinced they have COVID, even though, they might have been self-isolating. So that's one way that absolutely COVID could impact OCD. But for the record, that it becomes part of their obsessions that they get COVID. I've actually, surprisingly, not had anyone on my caseload that actually has kind of adopted, including kids with contamination and so forth, and they haven't adopted worry in particular about COVID. What's interesting, I have one girl on my caseload with OCD, and her grandfather, her mom's father, he has absolutely, the OCD is kind of, if he had symptoms all along, like indications of OCD, but now it's like through the roof, and he's debilitated by this particular obsession about COVID. That's one thing. The other aspect of COVID, though, is exactly what you suggest about like all these like closures and so forth, is look at this impact of the general stress level has gone up. So just like it would for any other mental illness, your OCD could well be exacerbated because your everyday mental health practices aren't there. You're not socializing, you're not getting exercise, you're up all night on your phone or whatever. So the OCD is just worse by virtue of, you've lost your typical coping strategies, if you will. And to that end, I've seen some of that. I have a couple of people now that are literally housebound by virtue of their OCD. On the other hand, you'll see some kids that are like, geez, COVID's wonderful because, of the lockdown. And great, wonderful, they don't have to go to school, so their OCD is decreased, right? It's quite interesting. And sorry, what was the last part?
In terms of the services, was it has accessing resources been more difficult with some of the closures?
Okay, so from that perspective, that's a whole topic in and of itself. And I can only give you my perspective. My perspective is that that absolutely is going to be far more difficult to access resources, even though, of course, central intake is still open. We're still open. Psychiatrists are still working. Let's be honest that people are probably not working to the capacity that they typically would, or particular resources are closed, although there's nothing in particular that comes to my mind that in terms of mental health resources that have closed. But the reality is that people are working through caseload, working through waitlist and so forth slower. So from that regard, yes, I would say access has been impacted.
And Hazel, did you have anything to add there before we move on?
I guess the only thing, it was interesting because Sandy and I actually had a brief discussion about that very thing last night, just kind of comparing whether we have seen an increase in any of our presentations, anxiety-based and OCD. I guess I can only say just clinically something that I have observed, because I do my day practice at psychiatry, but in private practice, the last several referrals that I've picked up have been OCD and have been people who, because of anticipated wait times, are not going the public route. So these would be newer cases. So I guess I can just kind of say that piece. The only other thing that I wondered is if you're looking at the compulsive piece of it, and if there's a lot of reassurance seeking as part of the compulsion, we now, because of COVID restrictions, the young person would actually have more access to the parent. So you may be seeing more of the compulsiveness around the reassurance seeking increasing, which means they might not be as, like that would be reassuring for them. So then you might not see as high degrees of distress like right now. But I wouldn't be surprised. If we do see an escalation just in general, and like Sandy said, often related to distress levels because people's mental health in general is suffering because of this. So.
Mm-hmm. Okay, thank you. I guess we do have more questions coming in, but maybe we can proceed with the presentation and at the end have an opportunity for some more questions.
Okay, yeah, we'll try to pick up our pace here.
Yep, and so I think with that in mind, the next slide we can kind of just quickly go through. I think we have people online who are quite familiar with CBT. So research around the treatment perspective, just kind of quickly say clinical standards would be for mild to moderate presentation of symptoms for OCD. First line of treatment would be recommended to be cognitive behavior therapy, CBT. We don't need to explain that any further. Moderate to severe presentation would often require combination CBT with medication, which you will see with any of the anxiety disorders. But there is a specific way to do CBT, which Sandy is, I'll leave it with her to follow through with the ERP, which is the exposure and response prevention. So I won't get into any more details of it because I'll pass it over to you, Sandy, just for time.
Okay, so I'm going to show you first. Sorry, guys. Okay, this bell curve analogy for anxiety. So this is, even though we all likely know it, it's still crucial for understanding if your goal here is to treat someone with OCD. And this is just simply the idea that if you're exposed, like you're about to present yourself to something that makes you anxious. So let's give an example of, a manager has to go give a big talk in front of 200 employees. As the time gets closer to that talk, the anxiety is going to go up. That's natural. Once the person gets up and does their talk and they get in the situation, they're at what we might call panic peak. Over time, as they get used to it, the body kind of calms down a bit and you see that anxiety dissipate. Okay, so we'll naturally call that like they've habituated to the situation. And it's important to recognize that naturally will occur. The body will get triggered, but then as you get exposed to it, your body kind of just naturally adjusts. And along with that, you hope that the thoughts change. Like once you start to relax, like, oh, okay, this is not too bad. Okay. Notice they're up on top, right at the peak, panic peak. I have that circled. Okay. That's where, if you've tolerated to get that far and your anxiety's hit panic, a lot of people will escape. Like, nope, not doing it. Can't do this talk. Or they get to school. No, cannot go in the school building. Get to a party. Nope, cannot. And so they leave. Okay. And that leaving, great, wonderful. It works. You all of a sudden don't feel the anxiety. Your anxiety drops away. But ultimately, you haven't worked through the anxiety, so it's just going to keep coming back. There's no way to get through anxiety other than to go through it. You can't go over it or under it. You have to expose yourself to it. This is the trick about OCD. The idea is that obsessions bring on anxiety, and just at that panic peak, and this could happen literally within a split second, the compulsion literally serves to relieve that anxiety. But you've ultimately just reinforced the obsession will just keep coming back. The goal of ERP is this. I've just explained compulsion happens quickly. It quickly relieves the anxiety, but it doesn't allow you to get used to the situation so that you can learn to be around situations where you have obsessions and you can work through them. So ERP is exposure. I'm going to expose you to a situation where I'm intentionally going to bring about these obsessions. And it might be that we'll just go natural, like the obsessions are happening anyway, or I might bring them about intentionally here in my office. And then I'm going to aim for you to prevent the response of the compulsion. So, so let's take, for example, this is the boy with autism and questionable pandas. He has severe autism. He's the one with the microbes. Okay, so notably has autism, but the OCD kind of came on very clearly just before summer of going to grade 5. And his compulsions, understandably, hand washing and avoidance. Let's look at, we're going to go slow. That's really important about exposure and response prevention. We're going to start with something that's not too threatening. It's like, not even getting on the ladder is a total avoidance, but you want to break it down. So instead of avoiding the doorknob, I'm going to sit here with you and I want you to use the doorknob, but only one finger. And don't worry, you can wash your hands right afterwards. Okay. And then I might say, all right, do the same thing. I want you to, and we do that until you get comfortable with it. So, that might be a couple sessions going around in the office, literally just touching doorknobs with one finger. And then it's like, yeah, okay, can handle that. No problem. Then the next step might be do that, but you're not washing your hands right afterwards. Let's aim for just a few minutes of you delaying the hand washing. Okay. Or sometimes I'll say, you can wash your hands when you get home. That's progress when you can make that whole 30 minutes or whatever. Then now I'm upping the ante. I'm going up the ladder. I'm saying, okay, same thing. You can handle the doorknob, one finger, but this time, no washing your hands. Okay. And I'm going to do this at a pace that is comfortable for them. This could truly take several sessions, but once you start to see progress, usually then the other symptoms aren't as difficult. Because you could look at this thinking, my gosh, you'll be in treatment until you're 100 years old at this pace. It picks up pace once someone starts to get control. Look over here, what I've just circled. Okay, that's we have here a delay in washing. Okay, that's going to be important. Delaying a compulsion is an important option to you. Okay, that's wonderful. The compulsion still happens, but if we can put a time delay in there, great. Here's an example. You've done several steps like that. You've gotten so further up the ladder. It might be, now I want you to hold the whole doorknob and hold it for a full hand. But I'll say the same thing. First, I'll let you wash your hands afterwards, and then it's no delay washing your hands. Now, no washing your hands. And you literally will step up your ladder. You might get up to the point where it's like this kid wouldn't touch his boots. Okay, so it's literally like, okay, I want you to touch the boot with one finger, and then you might build up to the point where you can take the boot off, and he's okay with it, and actually put it on the couch next to him. Right? So that is exposure and response prevention. Fairly straightforward. These are your options when you aim for in someone like, oh, it's quite simple. You say, well, just simply don't do the compulsions. It's nowhere near that simple. So we just gave an example of delay. So it might be like, and I'm going to coach you through it. And research shows that coaching, having a therapist to work with you, leads to a lot more success than just telling someone to go do it on their own. So you've put a delay now between your obsession and compulsion. You have other options. So let's look at the girl with all those, remember that really detailed, like 3 pumps of soap and wash the nail beds and all that. It might be changed. So it might be instead of 3 pumps of soap, let's try 2. Or then I might say do 5 pumps of soap because I don't want to start a new obsession like it's got to be 5 or it's got to be 2. I want to change it up. Or it might be like instead of doing, the right hand first and then washing the left, try the left hand and then the right hand. Okay, so you're aiming here for flexibility in thinking and flexibility in behavior. Shorten a compulsion. So especially with those rituals, it'd be like, okay, this time you get to wash your hands, but no nail beds. Okay, you're taking out that part of the ritual. This one, especially with adults, will suggest like go slow. Like you're getting one chance. To check to make sure you've made this to turn the stove off. Only one, so make it a good one. You better go slow and look real careful. And that's mindful, right? You're going to take a mindful approach. I'm pausing here for you.
So, yeah, I got it. So this here, again, this is not unfamiliar to anybody who works with anxiety. This subjective units of distress, often referred to as the SUDs. It's just a scaling unit. So we're looking at scaling and its fit with exposure work. So we use the scaling units. They're subjective, which means they're individual. So it depends on the individual's comfort level. We would use the SUDS scaling to determine what kinds of things go on that ladder. So it helps us develop the exposure ladder in the first place, but it's also used during the exposure work. So we want to track somebody's, or we want them to be able to track where their SUDS, their level of discomfort is during the exposure activity. And the goal is for them to maintain that exposure to the point that the SUDS level actually reduces, and even what that reduction by how much, all of that is individually based. So we just so that's an important piece of in the preparation and practice of the exposure work. And it's back to you, Sandy.
All right, so yeah, I might literally be in the middle of, I might start an exposure and say, okay, well, where are you at right now? And they might say like 3, and then I'll start the exposure. It's like, oh, no, I'm at a 6. And the goal is simply to aim for a reduction, right? Something where you feel okay to leave the office. And by the way, some of these things, absolutely, you'll encourage people to do these things at home. The next 2 slides are probably the most important when it comes to treatment. And you're going to see a difference here. If you do traditional, quote unquote, exposure and response prevention, you're not necessarily, if you do a lot of reading on it, you're not necessarily going to hear about this and these 2 things, which I think are crucial. Step number 1, you cannot make change if you don't have awareness that there's a problem. So your goal in working with someone with OCD is, do they even recognize that they're having obsessions? Do they recognize that this is not typical behavior or typical thought, that this is a mental illness? If you don't have that, you're not getting out of the gate. Okay, and research will show if you don't have that insight, your prognosis is poor. However, by definition in the DSM, that insight simply doesn't need it. It's absolutely feasible for a child and adolescent just developmentally to not have that insight. So right away, you have a big challenge in treating children and adolescents. Okay, what are some of the challenges that can happen? Is the child just simply doesn't have the maturity to recognize there's a problem with washing their hands. Or you might have someone who, they, they're on the spectrum and autism spectrum, and they think very black and white, like you're not convincing them that there's a problem with 8-hour showers. Or they don't have motivation to change because they're not going to stop and pay attention because it doesn't get in the way of their everyday life. Or, they're a child. So of course they're going to aim to get the compulsion done because it helps them feel better, right? Or they're so depressed that you know what, they don't even stop. They're not paying attention to their thoughts at all. So you can get challenges. So that is step number 1. So that's where I might do some cognitive challenging and saying what do you think about this? Is this an option? Solely to see if they have that insight. Will I, in the middle of exposure work, when I'm in the crux of doing OCD work, I do not engage in this big cognitive challenging. I don't think you're going to talk anyone out of OCD. Okay, that's important. Talking them out of OCD is not going to help. You really want them to recognize they're having set them up so they have these obsessions. And then this is important. What do you do when they're actually in the middle of an exposure activity, whether you've set them up to have the exposure activity or they're out in the community, like on their own, and they're having these obsessions and you're saying, okay, stop the compulsions, but what do I do? What do I think about? What does my body do? Okay, there's some, again, traditional ERP. I actually can't forward the slide because an email popped in. Can someone forward it for me? Okay, so again, different perspectives in the literature, and some research again will say you just sit there and the anxiety is just going to go away, right? You put that book bag on the bed, even though it's contaminated with germs, and just sit and wait for half an hour. Okay, and that's traditional ERP. My take is wait now. My view is my perspective. Our perspective is influenced by this Dr. Jeffrey Schwartz. He's a psychiatrist down in UCLA that did some PET scans back in the 80s. And he has identified particular brain areas that are impacted. And his view is, wait now, getting someone to think and overthink and just sit with their thoughts is not helpful. You need to get them thinking about something else. Okay, even though the obsessions are happening, let's focus your attention on something positive. Okay, so next. Oh, I can get it again here now. So again, neurons that fire together, wire together. Like you learning to ride a bike, it gets easier because you build those neural networks. That's what happens with OCD. You're going to keep letting those neurons fire, then you're just reinforcing the the OCD. So instead of doing the compulsion, let's get you doing something else. Let's get some new neural networks going. So this is where this is again, and this is, you might see this and be like, I've never heard of anyone talk about this before, because truly it's not what you'll see in traditional ERP. My take, it's still ERP, but you know, you want to be careful about specifically what the person does when they're feeling those obsessions. My take is redirect the body. Okay, so if your goal here is not to wash your hands, get yourself out of the washroom. Okay, if your goal here is, you know, to stop walking up and down the steps, then get yourself on top of those steps. Okay, so you get your body away from the situation where you'd engage in those compulsions. Am I oversimplifying things? Yes, but that's in the interest of time. And then you redirect your mind. Give yourself something else to think about. And so it might be like something you enjoy. That's the goal. And ideally, like, use up as many mental resources as you can. So, because it takes it away, takes the power away from the obsessions. So it might be like, I'll be working with someone and having their hand on the floor, which they're convinced is contaminated. And while they're doing that, I'll say, like, what are the capital cities in Canada? Or like, we're going to go through the alphabet and we're going to take turns and we're going to go name kids' names. So Abigail, Barbara, Catherine, and we take turns back and forth. Or, you know, I want you to tell me the lyrics to your favorite song. I'm giving you something else to think about. And this is our final slide. Okay, this again is powerful. And so notice here, I will tell people that your obsessions are like suitcases on a conveyor belt in an airport. Okay, and those suitcases are going around and around and around and around, and you can sit and look at those suitcases all day. And short, which is exactly like your obsessions. They're going to keep coming back and keep coming back and keep coming back. You have a choice. You can sit and stay with those suitcases, or you can say, yeah, I know those suitcases are there. I'm not denying them. So yes, I'm going to distract myself, but that doesn't mean I'm going to deny them. In fact, I'm going to embrace those suitcases and I'm going to move on. I'm going to think about the cruise I'm going on, you know, if we could go on a cruise. And I'm going to get my hands like on that captain's wheel, right? And so that's what I'll tell people is like, yeah, I know the conveyor belt is there. Okay, and what are you going to do? You're going to get yourself to a different part of the airport, right? Okay. Oh, sorry. These are our take-home messages, which I'm actually, sorry, Hazel. I'm going to pull them up all at the same time.
That's okay. Yeah. Okay. So just very quickly, these are the main messages. So there are obsessions and there are compulsions in OCD, and sometimes you have to be a detective to figure them out. Compulsions serve to relieve the anxiety that's created by the obsessions. They're generally themes. The therapeutic treatment is ERP. Primary goal is to help someone eliminate the compulsion. So bear in mind the obsessions are automatic, and so the focus is not on controlling them. They're automatic. Over time with practice, you eliminate the compulsions and the obsessions will decrease in frequency and intensity. Parents can reinforce the compulsions sometimes unwittingly. Be passionate and compassionate in working with people who have OCD. It's very challenging. So that was very quick.
All right. So thank you, folks. That's the end of our talk. And I see there's some questions that have come in.
Yes, yeah, we do have a couple minutes for some questions, so that's great. Someone is wondering, when does a compulsive thought become considered to be a rumination?
So I love that question, because a compulsive thought is not the same as rumination. Compulsive thought is very, remember, the thought in particular is an obsession. Usually if there's a particular thought, it's I'm worried that, like, what if? That's the obsession part. The compulsion, if there is a mental compulsion, it's usually like specifically a prayer or counting. It's not actually like I'm just randomly thinking. I'm following a rule of my specific prayer, or I'm counting numbers, or, I'm saying a statement in my head, like whatever. Rumination is not scripted. Okay, so typically, like, if you're going to see mental compulsion, it's usually like quite scripted, very concrete. It happens every single time. Rumination happens often. If you see rumination, it's almost only when you have the taboo topics. Okay, that violent, sexual. That's when you get the rumination. violent sexual immorality. And the rumination is about who I am as a person. I'm a pedophile. What if I'm a pedophile? What if I'm a homosexual? And people don't know it. Oh my gosh, I'm a psychopath. That's what the rumination is about. And where's the evidence to see if I'm a psychopath? So you go off script. If you're going off script, you have the obsession, like, oh, I just had an image of someone hanging, and you're going off script with, oh my gosh, what happened? That's rumination. Okay.
Okay. This may be going back to your slide on pandas, but can pandas fully resolve, or does it usually linger for some time?
It can absolutely fully resolve, because remember, what's happening here is your brain has been attacked by the antibodies. So especially if you can get in there and get the strep throat treated with antibiotics, then the infection, you can get rid of the infection, and bam, you've gotten rid of the OCD. You can, not always, but for some, the lucky folks, great, wonderful. But this is the trick, is that sometimes, strep infection might be around for 2 weeks, but the behavior comes on. But by the time someone goes to get help to say what's going on, and by the time someone's figured out this is pandas, then the infection is long gone, and the antibodies are still there. And the antibiotics treat the actual bacteria, but this isn't about bacteria anymore. This is about the antibiotics. So at that point, and it could have been around, it can persist for weeks to months sometimes. Then it comes down to you're using your traditional treatment of the SSRIs, the medications, and the talk therapy, and it's shown to be effective. The catch, though, is that this kid now, if they get strep throat again, bam, they can get the OCD come back so quickly. But now it's like, okay, I've caught on to this, so I'll tell parents, like, get the child to the doctor right away and get that swab done. So you can hopefully get medication in there. What about the kid who doesn't respond to the antibiotics? Can you get into, and it's very severe, you can absolutely get into some pretty hardcore treatments like plasma exchange and intravenous immunoglobulin and things that I know less about and I haven't seen much of here in Newfoundland.
Okay, I think we'll do one more question. Sorry, guys, we're running out of time. I know there's some more questions coming in. Do you see any patterns in terms of groups or types of people that develop OCD?
Yeah, so there's actually research to suggest that personality can play a piece. People with that inhibited, kind of quiet or more anxious temperament are more likely to develop OCD. OCD also, in boys, it will come in earlier, and you'll see it often earlier than girls. You'll sometimes see it with tics. If you have a young boy, 5, 6-year-old with tics and ADHD, be concerned that you might also see OCD come through. Yeah, that would be, I would say those are the biggest patterns that I see.
And Hazel, where that was the last question, did you have anything you wanted to note from the question period?
Nope, I guess just our apologies for, we did intend to leave more time, so I don't know if I'm sure if there are questions that you wanted to forward on, Annette, if there's a way for us to answer them, I'm sure we can make that happen as well, if you wanted to do that. So it's just that for people if they ask questions that we didn't get to.
Sure. So I'm actually here, and I actually have the questions pulled up, and there's some lovely questions here that I'd love to answer.
Oh, I can't even
if I'm able to copy and paste them into an email and maybe send out to the whole college or whoever's participating, I'd love to answer those questions.
Yeah, I can facilitate that, Hazel and Sandy, no problem. Yeah.
Thank you, folks.
Yeah, thank you. So I do want to take the opportunity, though, to thank Hazel and Sandy for this stellar presentation and for sharing their knowledge and expertise and experience with us. Certainly a lot of important information was covered related to OCD and the treatment of OCD. So we really hope this session gave you, as participants, some new knowledge and learning that you can use in your social work practice. Because it is through this type of knowledge exchange, reflection, and continued learning that we can enhance our skills in providing high quality services. So through their practices, certainly social workers are making a difference and significant impact on the health and well-being of individuals, families, groups, and communities. And this certainly includes work done in collaboration with our professional colleagues. Hazel and Santa, your work is certainly so vitally important, and your passion for and pride that came across in your presentation in working with clients who have OCD is certainly inspiring. So thank you for taking time for what I know is a very busy schedule for you both for doing this webinar for us this morning in celebration of Social Work Month. Just a reminder that the slides are available in the resource section of your webinar platform, so you will have those. And members may claim 1.5 CPE credits under the required category of workshops as per the NLCSW CPE policy for attending this webinar. And we also ask that you complete the evaluation form that's going to appear on your screen, because as always, your feedback is so appreciated. So on that note, I just want to say thank you again to everyone for joining us. Enjoy the rest of your day and stay safe.
Thanks, folks.
Thank you, Annette.